Bien, nous avons la chance maintenant d'accueillir virtuellement Enrico Hacher. Euh, pour vous présenter Enrico Hacher, c'est Enrico qui actuellement fait fonctionner le congrès de chirurgie vasculaire le plus important au monde. Nous sommes très heureux de l'accueillir. Il n'a pas pu venir physiquement aujourd'hui parce qu'un événement familial important l'attend, mais il va nous honorer de deux présentations. Je lui laisse la parole immédiatement. Jacques va dire un mot.
Enrico, it's a pleasure to see you online. You are a very good friend, and we accept all your instruction for these two sessions that you give, and I will meet you in next May and November. Thank you very much to be with us.
Also, I want to say a few words for it is important to receive you virtually, but we know the importance of this Congress worldwide, well known, and it is an honor for our National French Academy of Surgery to receive you. Thank you so much.
Thank you. Thank you very much. It's really a great pleasure to be here. Unfortunately, I love Paris. I've been to Paris many times for fun and for meetings. Dr. Beckerman used to call me, invite me once in a while to go to his meetings. And the only reason I am not there, I have to confess, because believe it or not, despite being an old man, I'm getting married.
Congratulations.
So I'm getting married in 2 days. So I thought that if I go to Paris now, which I considered, however, my future wife would divorce me before I get married. So I decided to not take this risk. But thank you so much for this very kind invitation. This society is so well known. The academy is so well known all over the world. And Dr. Haimovici, who is one of my mentors, used to talk to me about the academy and how important it was. He was so proud of it. He said that was the best recognition when he was I'm not so sure it was the surgery academy or the medicine academy, but he showed me in his office a big, certificate, and he said this is the most important thing I've ever received, recognition received in my life. Anyway, I have prepared the 2 videos because my internet has been very unstable, and I don't want to stop the presentation. Is it possible to put a video up, or I can, or I should just?
Yes.
Let's put the first on limb salvage, please. Thank you.
The internet is very good today with you.
Thank you. Thank you, Anthony, again, for allowing me to share with you some of our work, duplex-guided arterial procedures. I could not have given this talk without recognizing the help and the expertise by my partner, Dr. Natalie Marks. Without her, I could not have done most of these procedures. In the extremities, I believe that if you can see a lesion with a duplex scan, you can treat that lesion. And I'll show you a few examples. The only limitation that I have to say from the onset regarding this procedure is done under ultrasound guidance. If the vessel is circumferentially classified for equal more than 2 centimeters in length, that vessel really cannot be treated under ultrasound guidance alone. If the depth is equal more than 4 cm, you lose a lot of resolution. In many cases, you won't be able to make the correct decision. And you need an experienced ultrasonographer to be available during the procedure until they develop the robotic arm, and many companies are working on it. There are many obvious advantages to performing procedures under ultrasound alone or duplex alone. There's no radiation, no nephrotoxic contrast material, multiplanar, so the prosthesis won't be on your way. You can magnify the lesion or the area that you're working on, and you can visualize the entire arterial wall, not just the lumen. Of course, radiation injury and contrast-induced renal failure are always a problem, but usually in patients who are diabetic or have previous renal failure. There are many other advantages to interventional vascular ultrasound. You can select and place the balloon and the stent exactly where you want to, and you're much more accurate in measuring the size, the diameter of the wall than with a gyrography. You don't have to use IBIS, which is much more expensive, and you only use it once, the catheter. You can replicate. You don't have to rush and get the X-ray. In our experience, you can still treat the complications under ultrasound guidance. And at the end of the procedure, you can confirm the adequacy of the technique, both anatomically and hemodynamically. We have done over 1,500 cases in this series. We have many more now. That varies from the femoral popliteal segments to AV access to infrapopliteals, failing bypasses, and even as an assisted to carotid angioplasty and stenting, popliteal aneurysms, and many other types of procedures. We've got a first series that published 514 in 396 patients. You see that almost 40% of these patients have chronic insufficiency already adopted to the procedure. And the age group is more or less the same, I'm sure. At first, the patient were not this distribution of chronic disease there. And complexes.
So with the comments?
I don't think here, now the sheet is close to the lesion, the wire is going to visualize as well. And now inflating the balloon, you can see the hypoechoic. And as we deflate the balloon, there's a recoil. If the recoil is more than 40, this is not contrast material, it's powered outflow. Following this, we place a stent, done without radiation and without contrast. And now we're ballooning the stent as well. And we confirm the adequacy of the technique. Imagine the volume flow. And the volume flow, as I'm going to show, is very important. Piece left, and now per minute. You could also know whether you are doing a subintimal dissection or you're through the lumen. If you see the wire going in a spiral fashion, this is pathognomonic of subi. And now the wire is into the popliteal artery. We confirm it in two. And here you are the wire floating inside the vessel, so we know we are the I don't think we are listening very well. Can I interrupt for a second? Jack, should I just try to share screen the talk?
Pascal, can they share the screen?
We can at least try because the sound is not good at all. I cannot.
We understood very well what you say anyway.
Oh, you can hear well? Okay.
Yes.
So, I'm sorry. So let's continue then. Because I can't hear.
You can eventually comment without the sound or the video if necessary.
Yeah. Okay. So let's just go on. Thank you. Plane into the vessel, and here you can see perfectly well that now.
De faire un commentaire en direct.
Can you comment right now? This,
Right now, there's a dissection. There was an obvious dissection, and therefore we are correcting it. We did not get an X-ray. We just, with the ultrasound itself, we knew where it was, and we placed on the direct vision the stent to fix the significant dissection. In this case, it shows you that the wire is trying to go into the main lumen and is not going. So in some cases, we are failing. So we decided, can we find out whether we actually can preoperatively identify which cases we'll be able to cross and which we're not? So we did a grayscale media of the distal portion of the stenotic area in the SFA, And we had a tremendous good correlation. When the GSM was less than 25, we had the success in all cases. And when it's over 40, was dense plaque, we couldn't traverse in 12 cases. So we knew that we had to add another adjunctive techniques to be able to go through that plaque. So we already knew pre-op that this case would be very easy or very difficult. Okay. And this is we moved on to the infrapopliteal vessels, and we felt that we use the same criteria. Everything has to be done on direct vision by placing the wire into the artery all the way down through the lesion. And now you're seeing an angioplasty of the tibioperoneal trunk with good success. Absolutely no contrast, no radiation, and we're done with the case. So what we found out is when we measured the volume flow in the popliteal artery, we could actually predict which reconstruction is going to thrombose and which one will not thrombose. The ones that had over 100 ml per minute of volume flow, only 2.4% of them out of 247 cases had problems with thrombosis, partial or complete, in 247 cases, while the 21 that had low flow rates, almost 1 out of 5 caused thrombosed. This was an 82-year-old man, actually from Brazil, a physician who had had only one kidney and high creatinine, hypertension with a low ejection fraction, and a partially thrombosed popliteal artery that was embolizing. Went ahead, as you see, here's the proximal popliteal artery. We're measuring the diameter. This is the distal one with some stenosis. And now we know exactly where to place the graft and what size. We puncture the common femoral artery. The wire is moving into the SFA very easily. And we're going to cross here we are crossing the thrombus, away from the thrombus, into the lumen. We had to manipulate a little bit through that stenosis, but now we park all the way down the distal popliteal artery, the wire. We are bringing now a Viabond across the popliteal aneurysm and is deployed. We always balloon it because we cannot see the lumen of the PTFE because of the air in the wall of the PTFE graft. But after a couple of hours, you can repeat, in the recovery room, you can do the duplex scan, and usually it's not a problem. This is a patient who had we did a hybrid procedure, also with the ultrasound. A colleague of mine called me, he said, there's a huge internal iliac aneurysm, and we cannot excise it. There's so much inflammation. So I punctured the common iliac artery, and I place a 6 French sheet into the internal iliac aneurysm, and I coil embolize it. Of course, I use all the coils in the hospital, but this patient had no other option at that point that was safe. And then we place 1 stitch in the common femoral artery, and we're done. So that's this idea of using an ultrasound, a duplex scan for complex aneurysms. Was very valid in our experience, and we use that, as I'm going to tell you later on, in very large dissecting aneurysm of the celiac artery, hepatic artery, and other issues. So we've used that for hand AV malformation as well, a direct puncture into the lake rather than going through a very tortuous radial artery. We use even some patients for endoleak embolization of the endoleak in a type 2 endoleak of post aneurysm repair. And also, as I said, celiac aneurysms, where we went through the hepatic artery and we placed a graft. And of course, in the office, we have an office procedure where we do a lot of the SFAs and the angioplasty of AV access. It's a very simple procedure because we see from the puncture down to the end of the procedure that there's absolutely no leak or no problems. And if there's any problem, as I mentioned before, you can fix it easily with a balloon, a stent, or a glue. So this is basically an idea of what we do in these situations where we don't want to expose ourselves to contrast material. As a matter of fact, I myself have osteopenia in my left arm, so much because of radiation. I've done over 12,000 cases, and despite all the precautions that we think that we are really protecting ourselves, And somebody mentioned Dr. Dietrich, who has a radiation to his brain, unfortunately. We are being exposed all the time to radiation. So if you can minimize it, not necessarily exclude it completely, but if you can minimize it, I think this was good. And I had this approach since the early 90s. And despite that, I still got osteopenia because the other bones are okay, but the left arm, where is most exposed, is the one that is affected. So I just give you a little, quick brush on the.
Thank you very much for this first presentation. I have two short questions for you.
Thank you so much.
Thank you. Thank you.
I have two combined questions. First, do you use an echo duplex scan of high intensity, new generation, or old one? And second question, are you helped by an assistant, a technician in echo taking care of the probe?
Absolutely. Excellent questions. We use a good duplex scan. We change it every couple of years, of course, but we don't use contrast on the duplex scan. We just use duplex scan without any contrast material. Unfortunately, you cannot do it alone because the probe is short and you have to manipulate the wire and the stent, so you need somebody to help you. In some AV access, we can, but I would say that's much more comfortable to have a technologist or a doctor that is familiar with ultrasound techniques where they help. I have Dr. Natalie Marks, who actually is going to be my wife in 2 days after all these years.
Congratulations.
Thank you. And it's a very easy to do because she's there and she has done over 35 ultrasounds herself, thousands of ultrasounds herself. She's very comfortable. But as other people are trying to do now, in France, there's several groups that are doing AV access ultrasound guided procedures for a long time, actually. So it is done all over the world, but usually you need, I think, I have been working with a couple of companies to develop a robotic arm where you can press in the pedal, move the probe, but at this point, they're not available in the literature, in the market.
We share your opinion about the very important place of ultrasound in vascular surgery, acute use in the operating room. It is very important. Have you any experience with 3D representation, 3D echography?
Yes.
For vascular surgery?
Yeah, we did experimentally, again, work with the companies a little bit in cadavers and in models. And we use it in patients, but the only thing is very heavy at this point and it's cumbersome. It's not as, but we're very helpful to use the 3D ultrasound, especially to minimize and to speed up the case. So you know exactly where you're going with the needle from puncture to procedure. So I think it's great. It's going to be worked on several iterations, and I think it's becoming soon in the market.
Do you have any experience of TEVAR under the endoesophageal echo?
No, never done this before. I know that some people have tried it, the same way like people have done through the vena cava for infrarenal aortic aneurysm, but don't have experience with it. I have experience with intravascular ultrasound, and I like it and I use it, but I think it's being overused in the United States. Since the government started reimbursing for the procedure now, all of a sudden there's an explosion and everybody thinks it's indicated for everything. But I think there's a little bit of overuse of intravascular ultrasound, especially when you can have an ultrasound that's already there in your office or in your office procedure or in the operating room.
Did you learn ultrasound during your initial formation or recently only?
No, I learned ultrasound because the American College of Surgeons was looking for people that would be interested in teaching ultrasound to other surgeons. That back in the maybe 1982, 83. So I started learning by myself. I basically took courses and I learned by myself a little bit. And then all of a sudden I was an instructor because nobody else knew anything. So I was able to at least show them how to look at the carotid bifurcation, how to get the femoral artery, how to look at the veins, and that's how we started. So we were the first to teach, actually, surgeons to do ultrasound.
I'm not a vascular surgeon, but is actually in France, nowadays in France, do they learn ultrasound?
How is the program in the US about the training of young vascular surgeons? They have to learn echography, and how long is the program for that?
Yeah, excellent question too. I went to the program directors of vascular surgery in 1998, and I did give a presentation of the importance that surgeons should learn and should control ultrasound, because the cardiologists were stealing it from us. Yeah. Because part of our income as vascular surgeons in this country, in the US, is doing ultrasound. They're fairly well reimbursed, and you don't have to be a physician to do the test. You can hire a technologist. There's courses for technologists. So they spend a year or two, and then they get a certificate, and they can do in your office the ultrasound, intravascular ultrasound, echocardiogram, and every type of ultrasound possible. And you don't really have to do it yourself, but for you to be able to have this laboratory and the ultrasound, you need to take a test. RPVI is called. And this test was recently implemented the last 10 years, where you have to pass a test. There are several courses for that, but you can do it on your own time. You don't have to go. And it is recommended by most program directors in vascular surgery that the fellows take the RPVI test, which is a test theoretically, not necessarily practical.
Thank you. Fabien Tavot have a question. You have a question?
Yes, thank you. First, French comment. I want to thank Professor Achard for a very wonderful presentation, and your idea, it's a very important idea. Now in France, the vascular surgeons are sleeping. We are in danger. Yeah. And I am in particular.
It is probably the same worldwide.
Yeah, I'm involved in the vascular society, and we are explain that we have to mastering and to have the competence of the ultrasound, because the other specialty, and I speak about vascular medicine or the rest, yes, they are entrance inside the operative room, and they are saying that leave the surgery for the vascular surgeon, open surgery, and we will do the undo. And I'm not agree with that, of course. And I am one of them that I say that we have to mastering the competence of the ultrasound.
Thank you so much.
We are not sleeping.
We are